The next is transverse and oblique incisions, in which there are many name of incisions. First is cochlear subcostal incision, transverse muscle dividing, MC Burney incisions, oblique muscle cutting, phalangeal incision, Maillard incision, abdominothoracic incisions, retroperitoneal and extraperitoneal approaches. First is the vertical incisions, in which median incision, vertical incisions which allow the linea alba, it may be upper midline incision, lower midline incision, single incision. Significance, it is favored in diagnostic laparotomy as it allows wide access to the abdominal cavity. And the advantages of the midline incisions: almost bloodless, no muscle fibers are dividing, no nerves are injured, good access to upper abdominal viscera, very quick to make as well as to close, can be extended full length of abdominal curving around umbilical scar. And the disadvantage of midline incisions: care needs to be taken just above the umbilicus where the falciform ligament is, midline scar, bladder injury. The next one is the upper midline incisions, and the picture shows in which have upper midline incision, from this is the incision is start from xiphoid to above umbilicus. Division of peritoneum is best performed at the lower end of the incision just above the umbilicus so that the falciform ligament can be seen and avoided. Lower midline incision from the umbilicus superiorly to the pubis symphysis inferiorly allow access to pelvic organs. The peritoneum should be opened in the uppermost area to avoid injury to the bladder. Next one is full midline incisions. This is the start from xiphoid to pubis symphysis, and the also have the pictures and in which show the full midline incisions. Paramedian incisions, placed 2 to 5 centimeter lateral to midline over median aspect of bulging transverse convexity of rectus muscles. And the advantage: provides access to lateral structures, avoids injury to nerves, limits trauma to rectus muscles, permits good restoration of abdominal wall function, can be extended by slanting the upper end of the incision medially toward the xiphoid process if required. Disadvantages: time consuming, incision needs to be closed in layers, difficult extension superiorly as limited by the costal margin, tends to strip the muscles of their lateral blood and nerve supply, resulting in atrophy of the muscle medial of the incision. Transverse incision advantages: better cosmetically, stronger than vertical, less painful, good access to upper GI structures, more advantageous in children, transverse length of abdomen.